Howdy y'all, this is Dr. Jarvis. I'd like to talk about the identification of STEMIs. Our recent SOC exam has raised some concerns about this, particularly about the role of the patient's clinical presentation, and I'm hoping this podcast will help provide some clarification. First, I think it may be useful to review our definition of a STEMI. This is given in the SOCs in section 3310. A STEMI is the combination of a diagnostic ECG with an appropriate clinical presentation. It is not enough to have just the ECG criteria without the appropriate clinical presentation. It is also not enough to have the clinical presentation without the ECG criteria. As with most things in medicine, this isn't black and white. We must take all information available to us into consideration when making a diagnosis. It would be great if I could give you black and white absolute criteria for this. Better yet, wouldn't it be great if I could give you an iPhone app that you put clinical variables into and it spits out the diagnosis? Well, unfortunately, that app doesn't exist. Until it does, we will have to continue our practice in the murky waters of medicine, depending only on our clinical gestalt and some basic rules to help keep us afloat. So, with that in mind, our definition of a STEMI is the combination of both ECG criteria and an appropriate clinical presentation. Let's first review the ECG criteria since I feel comfortable most everyone knows these pretty well, and then we can discuss the more troublesome question of what is an appropriate clinical presentation. Turns out almost everybody universally will agree that these criteria for an ECG are truly the criteria for a STEMI. The appropriate clinical presentation is a lot more confusing and different people will vary on different things. The concept that we're going to talk about though is very well accepted. It's not just the EKG, it's not just the story, it's the combination. So the ECG criteria for STEMI are, first, greater than 1 millimeter of ST elevation in 2 or more anatomically contiguous leads. V1 and V2 alone are not used to determine STEMI. You also need the absence of imposters. Imposters are things like left bundle branch block, left ventricular hypertrophy, a ventricularly paced rhythm, and to be clear, an atrially paced rhythm alone is not an imposter, it's just the ventricularly paced rhythms. Benign early repolarization or pericarditis. And another note, an inferior STEMI, that is elevations in 2, 3, or AVF, may be called in the presence of a left bundle branch block. To explain why that is, it may be helpful to remember why we can't call a STEMI in the presence of one of these imposters. Each one of these imposters creates this artificial ST elevation that looks like or mimics the elevation that we see in an ST segment elevation MI. When you look at a left bundle branch block in someone having no symptoms whatsoever, going about their business, having a wonderful day, creates ST elevation in the anterior septal leads. That looks like an MI, even though it may not be. It does not, however, create ST segment elevation in the inferior leads. And as a result, if you see an inferior STEMI with a left bundle branch block, that elevation in the inferior leads is not caused by the left bundle branch block. Therefore, assuming you have the right clinical presentation, that would be a STEMI. So, again, an infarct imposter or a STEMI imposter is something that mimics ST segment elevation. We can't call a STEMI in the presence of that imposter because we can't say that the elevation is from the patient's myocardial ischemia or whether it's from the imposter. We can, however, call a STEMI, again assuming the presence of the appropriate clinical presentation, if there is no imposter. As an example, if you have a right bundle branch block, that should not cause ST segment elevation in the anterior leads like a left bundle branch block does. Therefore, if you do see elevation there, it's not from the right bundle branch block. You have to assume then that it's from a STEMI, again assuming that clinical presentation. So I've been thinking of a good way to explain this concept of a STEMI being the combination of ECG plus clinical presentation. It brought to mind equations and algebra and even a little bit of calculus. And after I had a little bit of a seizure thinking about calculus, I said, well, maybe what we can do is make this a nice simple equation and even add in some real numbers and say you have to have above a 10 or above a 7. And then I quickly realized this really would not work out very well. So instead, I'm just going to refer to this concept of an equation. And I would like to point out that this actually has been tried before. Lots of people, if you do a literature search on Medline or PubMed and look for clinical variable prediction rules, things that iPhone app where you can put the variables in and out will come a diagnosis, that's been tried a lot. And you'll see in the literature that it doesn't work out very well. And as a matter of fact, it doesn't work out even as well as clinical gestalt. So that's the reason numbers won't work. The concept, however, I think is valid. So let's start with the notion that a STEMI is the sum of these two parts, ECG criteria plus the appropriate clinical picture. That equals a STEMI. In order to call a STEMI, you have to have both. So let's take this first concept, the first option or possibility. You have strong ECG criteria, strong appropriate clinical picture. That is clearly a STEMI. For example, if you have crystal clear ECG, so you have huge elevations and a clear distribution, when I was at Temple College, I used to call the alien sitting on your face dripping its nasty alien drool into your hair. If you have that crystal clear EKG and a classic description of an MI, say a 52-year-old man, sudden onset of severe substernal chest pain, nausea, dyspnea that came on 30 minutes ago with exertion, that decision's easy. I don't think many of us are going to miss that. That is clearly a STEMI. So that's the case where there is a strong ECG criteria, strong clinical picture. That's definitely a STEMI. So let's take the next case, which I also don't think is that difficult. This is where you have a highly dubious EKG. This is the kind of ECG that you take out your magnifying glass and you stare really, really hard at one lead and you try to convince yourself that there really is more than 1 millimeter of elevation. It's essentially what I call the Rorschach ECG, where you stare at it hard enough, sooner or later you're going to be able to see the pattern you're looking for. So really dubious ECG and a highly questionable story. As an example, an 18-year-old male with nausea and vomiting, but no shortness of breath, no chest symptoms, no other complaints. Well, that's also easy. That's clearly not a STEMI. So that's the case where we have weak ECG, weak clinical picture. That is not a STEMI. It's the cases in between that are difficult. It's these next two. So let's say we have a patient that does not have chest pain. Can this be a STEMI? While it is much, much less likely that it's a STEMI, it isn't impossible. We can call a code STEMI for a patient without chest pain, but we'd better have some type of symptoms that we can attribute to myocardial ischemia. And we'd better have a very convincing ECG. So this would be the case of a strong ECG and a weak story. This combination is still a code STEMI even though they don't have chest pain, but they have to have some type of symptoms. A great ECG with no clinical picture is not a STEMI. And again, this is the situation where you should phone a friend. There are some clinical conditions that will cause ST segment elevation, real alien type ST segment elevation in a patient who's not having a STEMI. That is going to be the minority of cases, and in that situation, just phone a friend. Ask for help. Call the emergency physician at the hospital that you're transporting to and explain what you have. So, the other in-between case is the one where you have an iffy ECG with a strong story, say the classic chest pain patient. This can also be called a code STEMI, but you still need to meet the ECG criteria in the SOCs along with a great story. And I think this is where we run into trouble, because we take the iffy ECG, but we sort of miss out on the strong story. We end up with the iffy ECG and the iffy clinical story, and that's an iffy STEMI. Those are the ones I don't want us calling. Again, overall, I would prefer, if we're going to err, that we err on the side of calling it, and all of our cardiologists say the exact same thing. They would much rather you call it than not call it. But I think all of us would like to do as good a job as we can. Again, that's the reason we're talking about this. So I hope that this clarifies when we can call a code STEMI and how both components of the equation are needed. So I know there's been some discussion of this out there that I or Dr. Jarvis Dr. Gonzalez, in our podcast that we did, said that you must have chest pain to be a STEMI. Well, this just isn't true. And I apologize for any confusion that's out there. And if that confusion comes from something I said or something Dr. Gonzalez said in that podcast, I am very sorry. I actually even went back and I listened to that podcast again. And there are very few things, by the way, as painful as listening to yourself talk. But I can't find where this came from. I went back and listened to that, and I just can't find it. I really do want to know where it is, though. So if you can refer me to the podcast and try to help me out, because it's an hour and 11-minute podcast. Tell me where it is in the podcast, just roughly. Say, hey, go in and listen from minute 23 to minute 25. It's in there. Okay, I'll be happy to go back and listen again. And I really do want to hear that. I just haven't been able to find it yet. And I know that Dr. Gonzalez doesn't believe that you must have chest pain. He and I will both tell you that STEMIs, unlike NSTEMIs, by the way, the non-ST segment MIs, will both tell you that STEMIs are much less likely to occur without some type of chest symptoms. Now, sometimes it's hard to get that out of the patient, but with good history taking, there's usually some type of chest symptoms with a STEMI. Again, it's not always. There are, again, no absolutes. It's not always, but in most times, you will see that. And in the minority of STEMIs without any chest symptoms, the ECG is likely to be pretty convincing. So I'd like to spend the rest of this podcast going over some cases. Now, these are all real patients with real ECGs taken either from the Marble Falls system or the Williamson County system. And there's one exception to this in here, and I'll point that out when we get to it. So just as a reminder, all of the cases on the SOC exam, those were real. None of the case descriptors were made up. None of the ECGs were made up. We didn't use any generated ECGs. All of those were real cases that we called a code STEMI. So let's take a look at some cases here. So the first one is of a 53-year-old male. He's complaining of chest pain that began while playing tennis. He describes the pain as a substernal chest pressure. It's not radiating and is associated with some nausea. He has a past medical history only of hypertension. You see his vital signs there, and here's the ECG. So let's take a good look at that EKG, and I think we'll all see that this is a fairly strong EKG. We see some ST segment elevation in the anterior and septal leads. Now we also have the added benefit here, the cherry on top, if you will, of reciprocal changes in the inferior leads. And if you look closer, you'll actually see that there's some elevation in AVL. Now the AVL you have to look really hard at. Fortunately, you don't have to look hard at the elevation in the anterior and septal leads. So this is a case where you have a good story and a good EKG. So this is clearly a code STEMI. So our next case is a 58-year-old male. He has a history of liver failure from hepatocellular carcinoma. This patient gave us no history because when we walked up, he was dead. He was in cardiac arrest. We initiated resuscitation. His initial rhythm was a systole, and again, we didn't have any history. We didn't know anything at all about him. We got pulses back, and as a matter of fact, we got pretty decent vital signs. So there's the blood pressure pulse. We're bagging him around 8 times a minute, and his initial documented saturation was 88. So, post-ROSC patient, we get the 12 lead, and we understand why it's important to get the 12 lead, because if this were a STEMI that caused the arrest, he needs to get to the cath lab. So here is the first ECG. Now I think most of us would say this isn't a normal ECG, but as we stare at this, I think our eyes are probably drawn toward V3 and V4, and what we're seeing is some nasty T waves. So those are definitely concerning T waves, but it's not ST segment elevation. So we don't have a really strong case that this is a STEMI. However, we're worried about this, and this crew went ahead and did serial EKGs. Now the next ECG is substantially different. So as we take a look at that, not only did our T waves change, we now have ST segment elevation in the inferior leads, along with some depression in the lateral leads in AVL. This now meets our STEMI criteria. We clearly have the ECG criteria, and a post-ROSC patient is an appropriate clinical setting. Is he having chest pain? Well, at this point, I'm pretty sure if he could talk without the ET tube in his mouth, would clearly tell you his chest hurt. If for no other reason than we were jumping up and down on it. So post-ROSC patient with this ECG, I think is entirely appropriate to call code STEMI on. Next patient. This is a 94-year-old female. She's complaining of substernal chest pain that's radiating to her left arm. It's been going on for about 30 minutes, and there were no further details of the patient presented in the chart. She does have a history of coronary artery disease and has had stents placed in the past. Her blood pressure is documented as 187/159, and certainly if that is accurate, that's pretty high. Now her pulse is documented at 28, and I put a question mark on there because that's the only value I saw documented in the chart anywhere as to the patient's true heart rate. And when you look at the ECG, it's not the fastest thing in the world, but it's not 28. So I'm not quite sure what the true pulse was. There's also no respiratory rate given, so I can't help you with that. Well, here's the ECG. And this is not something I think we have to really spend a whole lot of time staring at. Our eyes are drawn down to the inferior leads, and we clearly have some ST segment elevation. We even have some reciprocal changes. So this is a code STEMI because we have a strong story and a strong EKG. So here we have a 68-year-old white male who is complaining of neck pain. He said this has been going on about 24 hours. He woke up yesterday with what he describes as a crick in his neck. And it was actually written in the chart, in parentheses, crick in his neck. So I'm sure that's what he said. The pain gradually got worse over the last 24 hours, and it's now sharp and radiating to his left shoulder. The pain is worse with palpation. We specifically documented that he has no chest pain and no chest pressure. He does, however, have a past medical history of coronary artery disease, and he's had an MI in the past. He also has diabetes. Those are his vital signs, and here's his ECG. I would love to be able to give you only ECGs that have no artifact. I would also love to be able to flip the magic flux capacitor switch on the ECG machines that eliminates all artifact. Unfortunately, I haven't been able to figure out where that flux capacitor switch is. Maybe we'll find it in the future somewhere. But what we see here is pretty much a non-diagnostic EKG. If you're looking down in the inferior leads with a microscope, maybe you can convince yourself that there's something there, but this is not diagnostic. The other thing you may be able to do is say, well, it looks like there's some elevation, but I think what you're looking at is the difference, the elevation of the ST segment above the PR segment. And this is probably a good place to review where we measure the ST segment. So the ST segment is measured one small box to the right of the J point, and I think everybody gets that. But our tendency is to say, well, that is in relation to the PR segment, and that's not correct. We need to measure the ST segment in relation to the TP segment. In other words, the segment following the T wave, not preceding the QRS. One of the reasons for that is that it is not uncommon to have depressed PR segments, particularly in pericarditis. That's the reason pericarditis is an imposter. It looks like you have diffuse elevations in non-anatomically contiguous leads all over the place. And you do have some ST segment elevation even when measured correctly. But what you really have that's really noticeable is that elevation in relation to the PR segment. And that's the reason that we measure it in relation to the TP segment, not the PR segment. So the crew on this patient didn't really like the artifact, so they appropriately ran another ECG. And here's this ECG. Again, no ST segment elevation. And again, that was a situation that we did not have a good story. As a matter of fact, this is a very weak story. Can a patient with a STEMI present with neck pain or pain radiating to his neck? Absolutely. But that's just not, it's not the best story in the world, and it wasn't the story that this patient had. This patient was describing musculoskeletal pain. This is pain that he himself described, and they're not always right, but he describes as a crick. It's been going on for 24 hours. and it's worse with palpation. Now my guess is if we had asked him more about this, I think he would probably tell us it's also worse with movement. So there's no reason that the pain from a myocardial infarction should be worse with movement. Not something to hang our hats on, but again, the more information we get, the closer we'll be to accurate. So that was weak story, weak EKG. That was not a STEMI. This case is a 57-year-old female who's complaining of left arm heaviness, nausea. She has no chest pain, no pressure, no shortness of breath. She does have a history of hypertension, diabetes, and hyperlipidemia, and you see her vital signs there. Here's the ECG. So in this case, what we see is a sinus rhythm without any diagnostic elevation. So let's think about this in terms of the context that we had in our recent exam. So let's go back to the clinical scenario. In one of those exams, this was not on our exam, but if it were, we would say something along these lines. This is your clinical vignette, 57-year-old female, left arm heaviness, nausea, no chest pain. This is the ECG. The question is this a code STEMI? Answer A, yes, there is diagnostic elevation. I don't think that's the correct answer because there is no diagnostic elevation. B, no, there is no diagnostic elevation. Okay, I like that, but let's look at the other options. C, no, the elevation is from a left bundle branch block. Well, that's not correct for two reasons. Reason 1, there is no elevation. Reason 2, there is no left bundle branch block. Let's say option 3 was no, it's not a code STEMI because the elevation is from left ventricular hypertrophy. Again, there are two incorrect things in that statement. 1, there's no left ventricular hypertrophy, and 2, there's no diagnostic ST segment elevation. So just as an aside, a little bit of test-taking strategy. A multiple choice test, and this is the way that I've looked at it, and I have to say I've been rather successful at taking multiple choice tests. Convert a multiple choice test into 4 true-false statements. As you read the STEM, that body of text up above the distractors, the options A, B, C, D, find out what the question is, cover up the distractors, and answer the question. Then once you've answered the question to yourself, look at the distractors, and apply a true-false statement to each one of those. So in the example, and for that line to be true, everything in it has to be true. If there's anything false in there, then that line is false, and that can't be the correct answer. So in the case of this patient, is this a code STEMI? No, because the elevation, so there's one thing, that assumes there's elevation, and there's not, so that has to be false, is from a left bundle branch block. That also is false. So you have 2 false statements in that distractor. That can't be the correct answer. And as another aside here, let's say that this patient had a right bundle branch block. Is this a code STEMI? And the distractor in question is no, because the elevation is from a right bundle branch block. All right, so that can't be the right answer because, again, there's no elevation. But even if there were, it wouldn't be the correct answer because a right bundle branch block doesn't cause ST segment elevation and is not an imposter. Therefore, that should never be the option. All right, so let's take another case here. This is a 70-year-old female. She's complaining of substernal chest pain, chest pressure that radiates to her back and her neck, and it woke her up 8 hours ago. There are no other symptoms, and she is in no apparent distress. She looks pretty happy. She does have a history of coronary artery disease and an MI. You see her vital signs there. So again, substernal chest pain or pressure radiating to her back and neck woke her up 8 hours ago. So let me just talk about this scenario for a little bit. We would not necessarily expect an MI classically to go on for 8 hours. We'd expect it to get better or get worse. Now, it certainly can do that, and it's not all that unheard of for it to last 8 hours. 24 hours is a little long, but we would expect it to have gotten worse in 8 hours. The substernal pressure pain radiating to the back, particularly that woke her up, that is very concerning. So this is a pretty good story here. Now, The catch, though, is she doesn't really look like she's in distress. And again, a STEMI doesn't have to look like they're in distress, but if they look happy and they're munching on their Cheetos, it doesn't rule it out, but it does make it less likely. Again, one more thing to put into the clinical picture. So, decent story in this case. We're a little concerned about the length of time and the no distress part, but let's take a look at the EKG. Now, here's what we see. Now, I don't see any elevation in this patient. So, in this case, we saw the clinical situation. The question, is this a code STEMI? Answer A, yes, there is diagnostic elevation. I don't see diagnostic elevation. Answer B, no, there is no diagnostic elevation. Okay, I'm liking that, but let's look at the others. No, the elevation is from benign early repol. Okay, well, there's no elevation, therefore it doesn't matter what we say it's from because there's no elevation. So that's not it. And D, there is no elevation because of a ventricularly paced rhythm. Well, there's no elevation and there's no ventricularly paced rhythm, so that's not it. Now, that doesn't mean this is a normal EKG because it's not. I see some ST segment depression that is concerning, and particularly with this patient with that history, I think I'm going to be concerned that perhaps this is a non-STEMI. Now, unfortunately, we can't diagnose that because we can't. The definition of a non-STEMI is someone with a non-diagnostic EKG, a good story, and positive biomarkers like troponin or CKMB. Now, we did do another 12 lead on this patient, and this is it. Now, again, we're not necessarily seeing we're not seeing any elevation, but we actually see more depression. So, again, a concerning situation for ACS. Perhaps it is unstable angina, or perhaps it's a non-ST segment elevation MI, but it is not an ST segment elevation MI. All right, next case, and this is the one that I made up, and I made it up because I didn't have a case handy to demonstrate. So this is a patient that I did see the other day in the emergency department. I just had to make the EKG up. So this is a 45-year-old African-American male. He is complaining of cough for 2 weeks. He's had a fever off and on. He has a very localized, like 1 centimeter, it hurts under my finger right here, not there, but here. What he describes as pleuritic chest wall pain, and it's to the left lateral wall of his chest. There's no shortness of breath and no nausea. So again, fever off and on, 2 weeks, he's been coughing, and now when he coughs, his chest hurts in this very localized area. He has a history of hypertension, and these are his vital signs. So here he has chest pain. This is not the most convincing chest pain in the world. As a matter of fact, I think we would all look at this and say perhaps there's an alternative diagnosis. So if we're going to call this a STEMI, we'd better have an incredibly impressive EKG, right? Well, here's our EKG. Now, I'm not terribly impressed with this ECG. What I see is a sinus rhythm with a right bundle branch block, but I don't see any elevation. So is this a code STEMI? A, yes, there is diagnostic elevation, not like an A. B, no, there is no diagnostic elevation. Okay, I'm kind of liking that. C, no, the elevation is from a right bundle branch block. Let's come back to that. D, no, the elevation is from a left bundle branch block. That's clearly not true. No left bundle branch block, no elevation. Let's go back and take a look at C, though. So is this a code STEMI? The option C is no, because the elevation is caused by a right bundle branch block. Does this patient have a right bundle branch block? Yes. Is the right bundle branch block causing the ST segment elevation? No. And no for 2 reasons. 1, there is no elevation. And 2, a right bundle branch block does not mimic a STEMI. Therefore, this cannot be the correct answer. All right, next case. A 77-year-old white male who's complaining of chest pain or tightness, and it begins suddenly while making his bed. He is alert and oriented on arrival, but he quickly goes into a VFib arrest. He was shocked twice into a perfusing rhythm, and those are his vital signs. We quickly obtained an ECG. So I would say, going back to this, that this is a pretty convincing story. I'm not sure how stories can get much more convincing than this. Chest pain, he drops in arrest, in a VF arrest. That's really the reason our system is built. It's to fix or to really find these folks and intervene, because we can make a big difference. And obviously we made a big difference in this patient's life. We shocked him, got him right back into a perfusing rhythm. Now for the ECG, and what we see is a pretty convincing inferior ST segment elevation MI. We see the elevation in lead 3, we see it in AVF, and we see nice reciprocals in 1 and AVL, and we see it across the rest of the lateral leads. Well, for that matter, we basically see it everywhere, except in the inferior leads and except in AVR. So, an interesting little aside, elevation in AVR, while we do not call that diagnostic for STEMI, that particular thing, in conjunction with an inferior, is pretty concerning for a proximal left main occlusion. What do you suppose happens if you have a sudden onset of a proximal left main occlusion? Well, you're probably going to have some pretty nasty chest pain, and then you're likely to go into cardiac arrest, which is exactly what happened. Now, here's the interesting thing. With this patient, we appropriately did CPR, we managed him, we defibrillated him back into this rhythm. Now, this was a patient from Marble Falls, and they're not particularly close to any STEMI receiving centers. So they had time to do an additional ECG. Here's the additional ECG. So you still see some elevation, you still see some depression, but let's go back and take a look at the initial one. It has gotten much better between this ECG and this ECG. Just an interesting little aside. All right, one more case here. This is a 46-year-old white male with severe substernal chest pain that's radiating to his left arm. He also has shortness of breath. This began while he was playing pool at a bar 3 hours earlier. During transport, the patient began complaining of left leg pain that developed into left leg paralysis. That's problematic. So we have a really strong story for ACS here. Severe substernal chest pain that radiates to the left arm and is exertional. And we also have a pretty strong case for an acute stroke. Acute onset of left leg pain and paralysis. That combination, acute stroke, acute STEMI, so I'll let you in on a little secret. The ECG looks like a STEMI. So that's concerning, right? Strong story, two things. So we have to be thinking about dissection here. And if you look, he has a history of hypertension. Those are his initial vital signs, not particularly hypertensive. So you may wonder, well, if you're normally hypertensive and you now have normal blood pressure, does that mean that perhaps you're a little hypotensive? Well, right around the time he started having left leg pain, left paralysis, this is what his blood pressure did. His blood pressure starts to drop. Now, this is very problematic. So here's his ECG, and we see some elevations, particularly in V3, V4. This isn't the world's most shattering elevations in the world, by any means. But what we do have here is a really strong story. So this is a good example of weak EKG, not non-existent EKG, and strong story. So this crew appropriately decided to call a code STEMI and transport to a STEMI receiving center. While en route, the patient developed the left leg pain, the left paralysis, and our crew went, code stroke, code STEMI, code stroke. I think this is a dissection. And sure enough, this guy was having a big thoracic aortic dissection. All right. So that is the end of the slideshow. That's the end of the presentation. Again, I just want to reiterate, for us to call a code STEMI in Marble Falls or Williamson County, just like for me to call a code STEMI in the emergency department, we need to have two things. It is the summation of the story and the ECG. It's both. It's not one without the other. You can have a weak EKG, not a non-diagnostic EKG, but a weak EKG as long as you have a strong story. You can have a weak story as long as you have a strong EKG. You just can't have both. Weak story, no chest symptoms, no nothing symptoms that we can really get ACS out of, and a weak story. It's the combination of the two. So I hope that that addresses any confusion that's out there about what my expectations about code STEMIs are. And I hope it addresses any confusion that may have come about from the SOC exam. As always, I welcome any questions. Please feel free to drop me an email or give me a call. Hope y'all have a great day.